malapit na, Lord. Okay, today our topic is about nervous regulation, so of blood pressure. This is divided into two. Today, it's about rapid control. Next Monday, it's about long-term control. So, ito yung within few minutes to increase or decrease the blood pressure. And then next Monday, it will be about control of blood pressure for within a day to a week or even up to a month. So, yun yung long-term control. Kailangan memorize nito by heart. Blood pressure is cardiac output times total peripheral resistance. Because in order to increase or decrease the blood pressure, you have to look into these parameters. Total peripheral resistance, ito yung summated individual resistance of all blood vessels arranged in series from the aorta to the atrium, so lahat, including the effect of blood viscosity. Cardiac output is stroke volume times heart rate. So if there is an increase in stroke volume, it will increase blood pressure. If there is an increase in heart rate, it will increase the blood pressure. If there's an increase in total peripheral resistance, it will increase blood pressure. So sometimes even if the cardiac output is increased, but there is a decline in total peripheral resistance, the blood pressure will either be the same or it can decrease. So kailangan alam nyo to. For example, even if the heart rate, I have a patient now, because the heart rate is about 40 beats per minute, but the blood pressure is still at 110. So ibig sabihin, there is something na nagko-compensate, either an increase in stroke volume or an increase in total peripheral resistance. You have to be familiar about that. So athletes, they have a low heart rate. This is a prototype example. They have a very low heart rate. Bakit, sir? Go, go, go. Huwag kang mahiya. So, athletes is a prototype. They have a low heart rate, let's say 50 beats per minute. And that is because they have a large stroke volume. It compensates. So, they have normal blood pressure despite having a low heart rate. And because the physiology varies, they have an increased stroke volume. That's why they don't need a faster heart rate to maintain a good BP. So, kailangan memorize ito by heart. So, the factors that influence cardiac output and or total peripheral resistance can control the establishment or variation of the blood pressure. And there are mechanisms, there are reflexes that can either increase or decrease. And ito yung pag-uusapan natin ngayon, the acute reflexes, the mechanisms by which blood pressure is maintained, increased, or decreased acutely. We have baroreceptor reflex, we have chemoreceptor reflex, CNS ischemic response, and abdominal muscle reflex. Ito yung mga ile-lecture natin today. So at the end of this lecture, kailangan familiar kayo sa mga reflexes na to. Okay, when we talk about reflexes, there is that vasomotor center, there is a cardiac center, and there is a sympathetic and parasympathetic. Ito lahat yung center of control of blood pressure. When we say vasomotor, nandun yan sa brain. When we say cardiac center, of course, it's in the heart. It starts in the AV node. Sunod-sunod na yan. And we will just talk briefly about sympathetic and parasympathetic. But there is one whole chapter about this, which will be lectured next semester. So, dun na yung mas detailed about autonomic nervous system. But sympathetic is fight or flight, meaning lahat pa-increase. But of course, there's an exemption. And parasympathetic, lahat is pa-decrease kasi this is more of a resting metabolism or resting. But of course, there's always an exemption. So, hindi siya hard and fast rule na sympathetic lahat pa-increase kasi sympathetic is more of vasoconstriction, but there are other vessels that vasodilate with sympathetic activity. You have to be familiar about the exemptions. Okay? So, ito lang yung itsura ng sympathetic, no? You have a sympathetic chain, and then lalabas yan sa sympathetic chain. It can either be into the The spinal nerve goes along with the spinal nerve, which affects the vessels supplying the muscles, or it can go to specific sympathetic trunk, which will supply the vessels in the abdomen, in the heart, something like that. So, hindi pa siya lalabas sa exam natin ngayon. I'm just trying to show you the anatomy because we will discuss this in finer detail in the next chapter. So, halos lahat ng arteries, arterioles, veins in our body have sympathetic and parasympathetic supply. So, yun lang. Okay. Ito yung vasomotor center. It's located on the lower end of the pons and the upper third of medulla. So, nasa gitna siya eh. That's the center for blood pressure. So, kung it's located bilaterally. Okay. Vasoconstrictor is on the upper medulla. Vasodilator is in the lower medulla. Kailangan nyo lang i-memorize yan. Wala na tayong other explanation to that because that's anatomy. And that's motor. Pag sensory, it's located bilaterally in the nucleus tractus solitarius, which is located in the posterolateral portions of the medulla. So pag motor, it's on the posterior lateral, while anterolateral naman yung motor. Okay? Sensory is posterolateral, while the motor portion anterolateral. Both the vasoconstrictor and the vasodilator is on the lateral. Nagkakaiba lang kasi si vasodilator is on the upper medulla while the vasodilator is in the lower medulla. So the output is via the sympathetic nervous supply to the heart and blood vessels. And sympathetic stimulation will cause an increase in heart rate. Ito yung fight or flight. So kunwari, biglang may sunog, so tatakbo ka, the effect to that there will be an increase in heart rate, and there will be an increase in the force of contraction of the myocardium. Okay, so it will increase the stroke volume if there's an increase in the force of contraction of the myocardium. It will also increase the total peripheral resistance because there is vasoconstriction of arterioles and veins, except the vessels supplying the skeletal muscles. Kasi mahirap naman yung tumatakbo ka, constricted yung vessel supplying the gastrocnemius, for example. Kasi kailangan mo ng increased blood supply. So the vessels, the sympathetic receptors in the muscles is using beta receptors. Kaya vasodilation siya. Pag alpha naman, more on vasoconstrictor yun. So sa lower extremity, sa muscles, the skeletal, the sympathetic chain to sympathetic supply to the muscles, the skeletal muscles, is of a different effect during fight or flight mechanism. Vasodilation sila. And that is to increase the blood supply to supply the increased demand of the muscles during an activity. Okay? So sympathetic stimulation, all in all, will increase blood pressure because you target an increase in stroke volume. That is from the vasoconstriction of the veins. So there is an increase in preload. Balik kasi yung dugo into the right atrium, so it will increase the stroke volume. At the same time, there is an increase in the contractility of the myocardium, so there is an increase in stroke volume. The heart rate is also increased because of sympathetic effect to the SE node. And so the cardiac output will increase. Plus, there is vasoconstriction of arterioles and arteries. Kaya the total peripheral resistance will increase, and this increase in cardiac output and total peripheral resistance will increase blood pressure. Okay? So this is has been shown by studies that ang katawan natin, hindi siya neutral eh. It's more on the sympathetic tone. Meaning, kahit rested ka, there is that sympathetic discharge kung saan the vessels are in vasoconstriction side. So it's slightly constricted. And then if you want to dilate it, i-decrease mo yung sympathetic activity para mag-relax. Okay? And then if you want to vasoconstrict it more, the sympathetic activity will have an increased firing. So palagi siyang in a vasoconstrictor or in a vasoconstrictor state or in a state of contraction. And this has been shown Kasi for example, you have an arterial BP of 100, no? And if you give a total spinal anesthesia, meaning you inhibit the sympathetic vasomotor zone, that's why there will be a drop of BP from 100 to 50. Okay? So yun yung evidence na meron talagang resting, you have this partial state of contraction because of a vasomotor signal, a sympathetic signal. And then if you are still in total spinal anesthesia, but you injected a norepinephrine, which is a potent vasoconstrictor. And so because of the effect of the norepinephrine on the vessels, it vasoconstricts. And so the blood pressure rises up to 140 millimeters mercury, which is higher than the resting BP because it's a potent vasoconstrictor. So after a while, the blood pressure will drop again because the norepinephrine is degraded. Kasi mabilis lang naman yung effect ng norepinephrine in the vessels. Hindi naman siya nagkukos ng vasoconstriction for a prolonged period of time. So ang dali lang. Kaya nag-wean out or it goes back to 50 millimeters mercury after the norepinephrine is degraded. So it will just go back to the 100 millimeters mercury resting BP once you remove the spinal anesthesia. So this is the proof that there is a sympathetic vasomotor zone. I hope you understand that. Okay, norepinephrine is the sympathetic vasoconstrictor neurotransmitter that acts directly on alpha adrenergic receptors. Okay, so at this point in time, ang sympathetic at parasympathetic are the preganglionic and postganglionic neurons. So the preganglionic and postganglionic nerves or fibers in parasympathetic uses acetylcholine, kaya sila tinatawag na cholinergic nerves. While the norepinephrine, the sympathetic chain, the preganglionic uses acetylcholine, but the postganglionic uses norepinephrine. Now, because it uses norepinephrine, it's adrenergic. Adrenergic nerves. Okay. So depending on the receptor, the effect will either be, most of the time, sympathetic will be vasoconstriction. The beta, it will cause vasodilation. Okay. Mahirap ba? So, meron kasi tayong receptors. Pag sympathetic, it's either alpha or beta or dopamine receptors. While parasympathetic, we have nicotinic and muscarinic receptors. This will not come out in your exam. What type of receptors? I'm just trying to show you that norepinephrine is being used in the postganglionic sympathetic chain, nerve. Okay, that's why it's called an adrenergic nerve. Okay, so alpha will cause vasoconstriction. Beta, if you stimulate the beta adrenergic receptors, it will cause dilation, okay, rather than constriction. Later na yung, naririnig niyo na ba itong vasovagal syncope? This is just a prototype example of stimulating the beta adrenergic receptor. Kasi kunwari, you inject epinephrine, there will be vasodilation to the muscles, the vessels supplying the muscles in the lower extremity. So, kunwari nakahiga ka, and then bigla kang umupo, tapos bigla kang tumayo, diba? The blood by gravity will pool in the lower extremity. Then, if you stimulate, mayroon pang stimulation ng beta adrenergic receptors, vasodilate pa yung muscles ng lower extremities. So, nabawasan, hindi agad na ibalik yung dugo to supply the brain. That's why there will be syncope. Kasi mag-fainting yung patient. So, there are patients na yung mechanisms to increase the BP back to normal is delayed, such as in elderly. Sila yung high risk for vasovagal syncope. Okay? And then, pag kunwari, umiiyak ka, stress ka, tapos hiniwalang ka ng jowa mo, increase yung epinephrine kaya they are risk for vasovagal syncope. Okay? Yun. We will now talk about the different reflexes. So since it's a reflex, there's an arc. So we start from a receptor, an afferent pathway, an integrating center, efferent pathway, this is now the motor, and then effector. So yung receptor, meaning ito yung nagre-receive ng signal, okay? That's for example, the baroreceptor reflex. There are receptors in the carotid and aortic sinuses. So carotid, you have the right carotid artery, the left carotid artery, and it will divide into internal and external carotid artery. So nandun tayo sa main, right and left carotid, common carotid artery. And then there is that aortic arch. I hope mo abot na kayo sa anatomy na ganyan, no? So ascending aorta and then aortic arch, then descending aorta. In the ascending and the aortic arch, there are 3 branches only, or I mean takeoff, or yes, branches. So it will start with the brachiocephalic artery, and then there is a left common carotid artery, and there's that left subclavian artery. So tatlo lang yung branches sa arch of aorta. So in the carotid and aortic arch or aortic sinuses, there are a lot of receptors there. So once these receptors are stretched, they will send signals. So they are stretched if there's an increase in blood pressure. So an increase in blood pressure will stretch these receptors, and these receptors will be stimulated. So yun yung effect ng receptor. And then if the impulses will go to the afferent pathway, which is the cranial nerve 9 and 10, that's vagus and, wow, kung susya ka, vagus, ang kapanan. So vagus na lang, no? Mas panay ako sa vagus nerve. And then glossopharyngeal nerve. And then it will now go to the vasomotor center, which we have discussed earlier. And then mamimili na siya kung increased BP, mamimili siya. So nag-increase in BP, the receptors are stretched. So stimulation travels via cranial nerve 9 and 10. So we'll go to integrating center. Oh, ang taas ng BP, ibaba natin. So efferent pathway will now inhibit sympathetic activity, and you want to stimulate the parasympathetic activity. Kaya ibababa yung blood pressure. So ganun lang yun. And then once you have the integrating center has decided to inhibit sympathetic and then increase parasympathetic activity, now go to the effector organs like the heart. So the heart rate will decrease, arterioles and veins will dilate, and then you will have the effect of the decreasing blood pressure. Okay? So eto siya, this is the artery, no? Dito kasi yung arch of aorta, there are a lot of aortic baroreceptors there, and then you have the carotid sinus. You have a lot of receptors there that goes to the glossopharyngeal nerve, and the other one goes to the vagus nerve. So it's mainly nervous in composition. The sensors are the baroreceptors. These baroreceptors increases in activity if they are stretched. Okay? So once it's stretched, it will produce action potential, and this action potential will travel into the cranial nerve 9 and 10. It will reach into the vasomotor center and decide whether to increase or decrease the BP. But again, this is just a short-term, moment-to-moment control of blood pressure. We're not talking about long-term activity. Pangmadalian lang siya. And then the sensors adapt to new pressure level if applied continuously for more than 3 days. Ito yung resetable. So, ibig sabihin, yung variation, mas effective si baroreceptor reflex in smaller variations. Let's say 110 yung BP mo, tumaas siya biglang 140, it will try to bring back to 110. Or 110 yung BP mo, tapos biglang nag-90, it will try to bring it back to 110. But for example, tumaas yung blood pressure mo, 150, it will try to lower it, pero talagang hypertensive ka, kalagi ka ng 150, no? Kalagi ng 150. So, because you are now at 150 for 3 days, nandun na siya sa 150, and it will try to increase or decrease and bring it back to 150. Yan yung problem sa baroreceptor din. Hindi siya kung ano yung flex mo na ngayon, na BP mo, ay meron mga hypertensive patients na, Dok, palagi naman wala effect lahat. Kaya, kasi yung baroreceptors nila are now on reset na siya at 150 or 160 millimeters mercury. Okay? So, ito yung nangyayari because of an increase in pressure, the carotid sinus will be dilated kasi increase in volume, and then it will now stimulate the baroreceptors. Yun yung i-increase yung yung firing rate. So if you look at the graph, this is arterial blood pressure, and then this is number of impulses. So as the arterial blood pressure rises, okay, pataas ng pataas up to 240, pataas ng pataas din yung sinus nerve, yung number of impulses from the carotid sinus. So kung bababa din on the opposite side, if the blood pressure will go down, then the impulses also increases. So ganun lang siya. Okay. So the firing frequency of the carotid sinus is directly proportional to the mean arterial pressure. If the mean arterial pressure will increase, the firing frequency is also increased. And the firing frequency of the carotid sinus is proportional to the pulse pressure. So if the pulse pressure will increase, then the firing rate of the baroreceptors is also increased. There is a steep curve, means that within the operating range of BP, 60 to 120, the carotid sinus is most responsive to BP variations. But below 160, halos wala nang effect sa carotid, sa baroreceptors. And beyond 120, hindi na rin siya masyadong effective. So, gusto niya talaga, mas effective siya between that 60 to 120 range. Okay. Yung baroreceptors, ang kailangan yung tandaan, 100, yung lower limit niya. Hello? Are you still there? Okay pa ba?
Yes, no.
Sorry, maingay yung girl. Joke lang. Hi. So, yung baroreceptors, if the BP goes down to 100, mag-i-start na siyang mag-act. 100 yung lower limit. Yun yung BP below 100. So, tandaan niyo yun. Baroreceptors, 100. Pag bumaba na siya sa below 100 systolic BP, then there will be a decrease in firing rate of the baroreceptors. Pag tumaas naman siya 120, there will be an increased firing rate of the baroreceptors. So I will talk about that increase or decrease in a while. Basta tandaan niyo muna, 100 si baroreceptors. Kasi si chemoreceptors, 80 siya. And then the CNS reflexes, 60. So baroreceptors, 100. Pag bumaba ang blood pressure mo by below 100, then there will be a decrease in the firing rate of the baroreceptor reflex. Kasi hindi na siya na-stretch. So if the baroreceptors are stretched, there's an increase in firing rate. And the vessel is stretched if there's an increase in volume and pressure. But if there's a decrease in volume and pressure, then there is no stretch. And then that's why the firing rate also decreases. So parehas lang siya. If the BP goes down, the firing rate of the baroreceptors also decreases. But the net effect is an increase in BP. Whereas if the blood pressure goes up or increases, the firing rate of the baroreceptors also increases. But the net effect is a decrease in BP. I hope that is clear. So the lower limit is 100 millimeters mercury for the baroreceptors. Okay, so let's do an experiment if both of the carotid arteries are clumped. Okay, they are clumped, both carotid arteries. There will be a decrease in BP. No, pabagsak yung BP nun. But because of a decrease in BP, the baroreceptors will have a decrease in firing rate. So once there is a decrease in firing rate of the baroreceptors, the net effect is an increase in sympathetic activity in the vasomotor center. while inhibition of the parasympathetic. So what will happen is immediately tumaas agad yung BP, no? Tingnan mo, at 2 minutes, you have clamps, immediately, no? Biglang naging 150 ang BP. And it will try to maintain that for, ilan ba to? So, 1, 2, 3, 4, 5, 6, 7, 8. Yan, 10. It will try to maintain that for 10 minutes. Okay, 10 minutes. But once you have released the carotid, the clumping on the carotid artery, then tataas. Marirealize nyo, taas na naman yung BP. And then there is that stretch. And then there will be an increased firing rate of the baroreceptor. So the vasomotor will try to be sympathetic and will try to stimulate the parasympathetic. And that's why the blood pressure will go down. So ito, yung baroreceptor effect will only last for, let's say, an hour, but not more than that. Kasi pang acute setting lang siya. Okay? Reduced carotid sinus pressure results to decreased signals from the baroreceptors. Kailangan nyo yung tandaan. I-memorize nyo yan. Lalabas din sa exam. A decrease in the stretch or a decrease in pressure will decrease the stretch in the baroreceptors. And that's why there is also a decrease in the firing rate of the baroreceptors. So when there is a decrease in the firing rate on the baroreceptors, so the effect on the vasomotor is also inhibitory, meaning you inhibit the bumaba kasi yung BP, no? So you want, kailangan mag-isip kayo. So bumaba yung stretch, bumaba yung BP, bumaba yung stretch. So decreased firing rate in the baroreceptors. So you want an increased BP. So the net effect will be an increase in firing rate of the sympathetic nerve, while there is a decrease in the parasympathetic. Para tumaas yung BP. Okay? So, for example, this is just an example kasi the baroreceptors can increase or decrease depending on the change in BP, the variations of the BP. All right? So, for example, tumaas ang BP at the carotid sinus. So the receptors in the carotid of aorta will stretch. Okay, so you have to be with me in this process. So increase in BP, increase in the firing rate of the receptors. Okay, so it will travel to the vagus and glossopharyngeal nerve. So it will activate A2 receptors in the vasomotor center. So just know that the firing rate will go to the vasomotor center and stimulation of inhibitory interneuron, because don't be confused about this inhibitory interneuron, because meron kang i-inhibit, meron kang i-stimulate. So ganun lang siya. Ganun lang yun. So the net effect will be inhibition of preganglionic fibers of the sympathetic nerve. So ang mangyayari, if you inhibit the sympathetic, okay, so you want to inhibit sympathetic, but at the same time, you want to facilitate the parasympathetic. So the next effect is a release of norepinephrine, a decreased release of norepinephrine. So there will be decreased stimulation of the beta-1 receptor. Okay lang, hiya naman ako sa inyo. Kalma lang. So decreased stimulation of the beta-1 receptor of the heart and receptor of the blood vessels. So the net effect will be a decrease in heart rate, a decrease in the contractility. There will be vasodilation of the vessels kasi nga you have inhibited the sympathetic and you have increased parasympathetic activity. So this will be more of vasodilation than vasoconstriction. So because of these effects or activities, the stroke volume will rise, the cardiac output will rise, peripheral resistance will drop, and the net effect will be a decrease in blood pressure. So if there is a decrease in blood pressure, the opposite. Lahat to pabaliktad. Kaya kailangan nyo itong maintindihan. Kailangan nyo siyang ma-memorize. Kasi in the exam, you will be asked what will be the activity in the reflex arc once there is either an increase in BP or a decrease in blood pressure. Nakuha nyo ba yun? Naintindihan nyo yun? Ang minimemorize ko lang is increased BP, increased firing rate of the baroreceptors. So because of that, what will happen to the net effect? Because increased BP, you want a decrease in blood pressure. So the net effect will be a decrease in sympathetic and an increase in parasympathetic. For example, the BP decreased. There will also be a decrease in the firing rate of the baroreceptors. And I want an increase in BP, so I will stimulate sympathetic and I will inhibit parasympathetic. So that's how I memorize that. I hope this is clear to all of you. All right. So, ganun lang siya, increase in BP, increased firing rate of baroreceptors. So there is a decline in sympathetic outflow and increase in parasympathetic outflow. If the BP decreases, there is also a decline in the baroreceptor firing rate, and the net effect is an increase in sympathetic outflow, while there is inhibition of the parasympathetic outflow. So blood pressure will rise again. So ganun lang siya. So these baroreceptors nag-a-act siya strongly or is being stimulated if the BP decreases less than 100 or if the BP rises above 120. So ganun siya, 100 to 120. Yung sinasabing 60 to 120 sa book, yung ibig sabihin, below 60, wala na siyang, it will not act farther. For example, the BP, pag nagda-drop pa lang siya ng 90, mag-a-act pa si baroreceptor. But if the blood pressure is already at 50 or 40, ibang mechanism nang kailangan mo doon. Hindi na si baroreceptor reflex. All right? I hope that is clear. Compensatory responses to a drop in blood pressure secondary to hemorrhage. So kanina yung example natin is an increase in BP. So let's try to look at if there is a drop in pressure. Okay, so a decrease in arterial pressure means in the firing rate of the baroreceptor. So then we want baba ang BP, so we want an increased BP. So we will stimulate sympathetic. We are going to inhibit parasympathetic. So what will happen is the AZ node, you have decreased parasympathetic, you have increased sympathetic discharge to the heart, so the AZ node will be stimulated, the heart rate will increase. Okay, so because you have also stimulated the sympathetic discharge to the heart, there will be increased contractility of the myocardium, and so the stroke volume will also rise. So increase in heart rate and increase in stroke volume, that is tantamount to an increase in cardiac output. And you have increased sympathetic activity in the veins. So because of that, the veins will vasoconstrict. It will try to deliver the extra blood into the right atrium and dagdag volume yan. So the net effect will be an increase in stroke, causing an increase in cardiac output. You have also increased sympathetic discharge to the arterial. And so these arterials will vasoconstrict, and that's the reason why the total peripheral resistance will increase. And so an increase in cardiac output plus an increase in total peripheral resistance, the net effect is increase in BP. Okay? Ganun kayo mag-explain, no? Para ang tali-talino mo lang, tinanong ka during rounds, oh, there is a decrease in blood pressure. What do you think will happen to the baroreceptor reflex? Yes, doc, because of the decrease in blood pressure, the baroreceptors have a decrease in the firing rate. The net effect is a decline in parasympathetic and an increase in sympathetic. In the heart, because of an increase in sympathetic, the heart rate increases. So in the heart, because of increase in sympathetic activity, the stroke volume increases because of increasing contractility. And in the veins, these are also vasoconstricted, and so it will increase the preload. All of these will increase the cardiac output. In the arterials, it's also constricted, so the total peripheral resistance increases. An increase in cardiac output plus an increase in total peripheral resistance will increase the blood pressure, and I thank you. Ganon. Ganon ang pagsagot niyo sa rounds para ang sound niyo sobrang talino. Alright? So, diniscuss na natin kanina, what's the effect on the baroreceptor reflex arc if there is also an increase in blood pressure. So opposite naman. So again, how I memorize it is increase in BP, increase in firing rate of baroreceptor receptors, but the net effect is a decrease in BP. So I want to inhibit parasympathetic. A decrease in BP ang gusto ko. So I want to inhibit the sympathetic, and I want to activate the parasympathetic. On the opposite side, if there is an increase in BP, increased firing rate of baroreceptors, so I want to decrease the blood pressure. So I will try to inhibit parasympathetic, and I will try, wait, nagulan tuloy ako. So increase in BP, increased firing rate of baroreceptors. So I want to decrease the BP, no? So ang mangyayari yan dapat is increased firing rate of the parasympathetic, and then decrease BP, no? So parasympathetic para mag-vasodilate. And I want to inhibit the sympathetic para decreasing heart rate, decreasing stroke volume. Oh, ganun lang siya, no? Hi. So pagdating niyo sa exam, ganito yung mga tanong sa inyo. You will be given a case or na tumaas yung BP, and then you will be asked what are the effects on the reflex arc. All right? We will now go to chemoreceptor reflex. So kanina si baroreceptor reflex, by stretch siya. It acts on the stretch of these receptors. Dito naman, since chemo naman siya, chemicals, these receptors are stimulated if there is a change in chemicals. Let's say a low in oxygen or increase in cardiac output or a high in blood, in H+ in the blood. So for example, there is a drop of blood pressure. Because of a drop in blood pressure, a drop in blood volume, the oxygen will be decreased. Then there will be high cardiac output. There will be high in H+ in the blood. And these chemoreceptors will also be stimulated. So these are also located in the bifurcation of the common carotid arteries and the aortic arch. So parehas lang siya sa baroreceptors. And then the afferent nerves are also cranial nerve 9 and 10, and the efferent nerves are sympathetic nerve only. So, yun yung kakaiba niya sa baroreceptors. Kasi si baroreceptor, both parasympathetic and sympathetic. So, ito si chemoreceptor reflex, more on sympathetic nerve lang siya. So, it can either stimulate the sympathetic or inhibit the sympathetic. So, ganun lang yung activity niya. So, integrating center is still in the vasomotor center, and then the effector are the arterioles and the veins. So, the net effect will still be the same. So increase in BP, we will try to decrease the BP. If there is a decrease in BP, we will try to increase the BP through this chemoreceptor reflex. Okay, so for example, if there is ngayon, the chemoreceptors is, it acts more if the BP declined by 80 millimeters mercury. Kanina si baroreceptors, it acts once its activity is stimulated once the blood pressure drops below 100. Ito, si chemoreceptors, once the BP drops by 80. Kasi nga, the low oxygen, high carbon dioxide, and H+ is more, mas nagmamanifest siya. BP is now below 80. So for example, 90 pa lang yung BP, halos hindi pa naman mag-change auto-saturation. Parang ganon. So this is more stimulated. The chemoreceptors are stimulated if the blood pressure drops by 80. So there is a decrease in blood flow. Because of that, there will be a decline in O2, an increase in carbon dioxide, an increase in H+. And it will excite the signals to the vasomotor center. There will be an increase in sympathetic outflow. It will vasoconstrict the arterioles and the veins. So it will increase the total peripheral resistance and increase the arterial blood pressure. So ganun siya. So somehow, it will try to increase the BP. So magkasabay sila, no? Kasabay sila si baroreceptor and chemoreceptor reflex once the BP drops to 80. Pero if the BP drops below, 100, but not below 80, si baroreceptor muna. However, if the BP drops below 80, sabay sila, both the baroreceptors and the chemoreceptors will act together to increase the blood pressure. All right? Hi. So let's now go to low pressure receptors. This time, there are receptors in the atrium and the pulmonary arteries, but these are more of, mababa kasi ang pressure sa atrium eh. Di ba? Right atrium has a 0 to 5 millimeters mercury pressure, whereas pulmonary arteries has a blood pressure of not more than 35 millimeters mercury. Kasi anything above 35 millimeters mercury, mataas na pressure na yun. So mas mababa ang pressure nila. So they act as, these atrial pressure are more of a low pressure receptor. So atrial reflexes activate the kidney, the volume reflex through increase of atrial natriuretic peptides. So ano tong atrial natriuretic peptides? Nakakaloka. So for example, there is an increased volume in the right atrium or in the left atrium, ang laki ng volume. So it will also, because of increasing volume, it will also increase in pressure. So these receptors located in the atrium will be stimulated to release atrial natriuretic peptides. Atrial natriuretic peptides will now go to the kidneys, and the net effect. These are our endogenous diuretics. This atrial natriuretic peptide. So once it goes to the kidney, it will cause diuresis. So iihi ka, and then once there is umihi ka, and then the volume will now decline. Kaya mababawasan na yung volume in the right atrium and left atrium. Okay? So at the same time, for example, there is an increase in volume and pressure in the right and left atrium. There is a decline in antidiuretic hormone. Ito yung vasopressin, no? So vasopressin is antidiuretic hormone, meaning hindi siya magpapaihi. So ang gagawin mo, kasi ang dami na ng volume, you want to inhibit the antidiuretic hormone. Okay? So ganun siya. Okay. Atrial reflex control the heart rate. This is the vein bridge reflex. A direct effect to the increased atrial volume will stretch the SE node, and it will stimulate vagal and sympathetic nerves to increase the heart rate. Ito yung tinatawag na vein bridge. You have to memorize this because this will come out in your exam. So an increase in volume in the right and left atrium, more so in the right atrium, will also increase the heart rate. So ganun siya. Increasing volume in the right atrium increases the heart rate. And this is a functional mechanism. Kasi nga, tumaas yung volume eh. So kailangan siya i-increase yung heart rate para ma-deliver agad yung volume in the right atrium. You don't want too much volume in the right atrium kasi tataas yung pressure sa right atrium. We don't want the right atrial pressure to be higher than 5 millimeters mercury. Kasi pangit yun, di ba? The veins cannot drain into the right atrium. There will be peripheral edema. Kaya we want to increase the heart rate so that there will be faster removal of volume in the right atrium. So that's the vein bridge reflex. Oh. Hi. Sinus response. Favorite ko to because I have a lot of patients na admitted because of cerebral infarction. So this is very powerful. You have to understand it. This is very powerful. It's because of the infarction in the brain, all mechanisms will be towards increasing the blood pressure. Kaya mapapansin niyo yan clinically pag pumunta kayo sa emergency room, lahat ng mga na-admit ng mga stroke patients, sobrang tataas ng BP nila eh. Ang hirap ngang ibaba. That's why you have to give, let's say, nicardipine to lower. It's an IV drug, intravenous drug, to lower the BP kasi hindi kaya yung tablet. Diba pag tablet, i-absorb pa yan sa intestine, pupunta pa yan sa liver, kaya matagal-tagal pa yung effect. So, kaya nag-intravenous kami para diretso, wala ng first pass effect, diretso na sa vein, and then we want to lower the BP agad-agad. So, their blood pressure is so high because of this ischemic response, and this is a mechanism in your body to help you survive. Kasi kung infarcted yan, meaning the cerebral arteries are obstructed or somehow there is a decreased blood supply to the brain. And so you want to increase the BP para meron kang continuous supply para yung infarcted size will not be big. Okay? So you will try to save infarction kasi ischemic pa lang siya eh. Ischemia means a decrease in blood supply. There's an imbalance between oxygen supply and demand. While infarcted is dead na yung muscle. So you want to decrease the dead muscles, the infarcted size. Kaya pag ischemia pa lang, ang laki na ng effect to, oh my God, wala akong, anyway, pag pumpasok, sana makapasok sila, no? Okay. So chemoreceptors in vasomotor center respond by increasing sympathetic outflow of arterioles, causing intense peripheral vasoconstriction and increase in total peripheral resistance. The blood flow to other organs such as kidney is reduced, and this is to attempt to preserve blood flow to the brain. The mean arterial pressure rises to life-threatening levels. Sobrang like 180 to 200 ang tataas ng BP nila. And the CNS ischemic response is one of the most powerful of all the activators of the sympathetic vasoconstrictor system. We call it the last-ditch stand. Kasi pag hindi to mag-act, you will really die. Kasi nga walang blood supply sa brain, kaya itataas mo yung BP para makapasok yun. Di ba ang blood flow natin is from higher pressure to lower pressure? So if there is somehow an obstruction there, you have to increase the BP higher than the pressure in the obstruction para to augment the flow into the obstructed cerebral artery. Okay, that's why the blood pressure is so high, 200, 180. So activated, this is also activated if the blood pressure is below 60. So if the BP is below 60, the CNS response will be activated. Unlike baroreceptors, 100 pa lang, it will act already. The chemoreceptors at below 80 millimeters mercury, it will now be stimulated. This CNS response will only be stimulated if the BP is below 60. Okay, so take note of that. But once the BP is below 60, this ischemic response will be activated. It will be so powerful that the BP will rise. Okay, so dati mga below 1990s, yung management ng mga cardiologists at saka neurologists, pag may dumadating na stroke patient, cerebral infarction, matataas ang BP nila like 180, 200. So, yung pagkakaintindi namin na ang cause ng infarction is the increased BP at that time, no? So what they wanted to do is to lower the BP rapidly. They wanted to give medicines, antihypertensive medications, to lower the BP rapidly, like from 200 biglang ito-drop nila to below 130 millimeters mercury. And based on their findings, ang daming namamatay kahit binababa nila yung BP agad-agad to 130. Di ba, mataas ang BP. Maraming namamatay, yung taas-taas ng mortality. So they conducted a study, and then they found out that you don't have to lower the BP too much because the high BP is a physiologic response. Nag-iintindihan niyo ba ako? If the blood pressure dropped to 60 and because the BP is now 50 millimeters mercury, mamamatay si brain. There will be ischemia to the brain. So ayun, nag-ischemia si brain. So CNS ischemic response will be stimulated to rise the BP, magiging 200 na siya. And so if you try to do something about that, if you fight that normal physiologic response, kaya tumataas yung mortality. So ngayon, there is now a change. There's now a change in guidelines. What we do now is we don't lower the BP as much as below 160 millimeters mercury. So pag dumating ka na 200, 210 yung BP mo, if it's cerebral ischemia, we will not lower your blood pressure so fast up to, let's say, 170, 180 lang. Okay? Unlike if it's cerebral hemorrhage, iba naman yung mechanism nun. That's because of increasing BP, increased flow, increased bleeding. You want now to lower the BP fast enough, below 160 millimeters mercury, para decrease yung bleeding to the brain. So, but what we are talking about is CNS ischemic response. Hindi bleeding, ha? Pag nagkaroon lang ng cerebral ischemia, there will be a rise in BP because of this CNS ischemic response, and you don't want to touch that response. And that's why yung mga resident ko, tumatawag sila, na-stroke yung pasyente, left-sided body weakness, the BP is now 200, nagagalit ako pag binibigyan nila, binobombahan ng nicardipine, 2 milligrams, drip ng sobrang taas, and then biglang, doc, yung BP 130 na. Tapos sila, okay lang, doc, 130 na yung BP. Ako, in my mind, natatakot ako kasi lalaki yung infarcted size. So, ayoko nang ganun yun. So, dapat slowly lang yung pag-lower mo ng BP. You have to recheck the BP every 30 minutes or every 1 hour. And then, depending on the response, then that's the time you slowly increase the nicardipine, or you even decrease the nicardipine if there is much decrease in BP. I hope this is clear. Oh, so cerebral ischemic response is there is a, kanina, pag cerebral ischemia, automatic yan, increase in BP through increased sympathetic activity and a decline in parasympathetic activity. Itong Cushing reaction is another example or a different type of cerebral ischemic reflex because Ang nangyayari dito sa Cushing's reaction is mataas ang pressure in the cerebrospinal fluid. So if the pressure in the cerebrospinal fluid is higher than the mean arterial pressure in the periphery, maiipit si brain. Okay, so the arteries kasi is from outside going into the brain. So pag mataas ang cerebrospinal fluid pressure, makukonstrict mo yung, maiipit mo yung vessels, kaya decrease ang blood supply to the brain, magkakaroon ka ng cerebral ischemia. So it's a different mechanism kasi yung pinag-uusapan natin kaninang cerebral ischemia, ito yung meron kang thrombosis or atherosclerosis in the cerebral artery and then nakakos ng stroke. Ito naman, para kang magkakos ng stroke but in a different mechanism. So this is an example of the response to cerebral ischemia. If there is an increase in intracranial pressure, it will compress the cerebral blood vessels, leading to cerebral ischemia and increased cerebral PCO2. So the vasomotor center will directly increase sympathetic outflow and cause a profound increase in arterial BP. So ganun siya. So cerebral ischemic reflex pa rin siya, CNS ischemic response, but kakaiba lang yung mechanism niya. This is more of an increase in intracranial pressure higher than the mean in the periphery. So we call that Cushing reaction. But again, this is still a type of CNS ischemic reflex to increase the BP. So you don't do anything about that also. Otherwise, if you lower the BP too rapidly, you increase the infarcted cerebral size or you augment the cerebral ischemia. Okay. Now, I think this is the last type of abdominal compression, of the reflex, acute way to increase the BP or decrease the BP. This is abdominal compression reflex. So if there is ischemia to the abdomen, ganun din, sympathetic activity, it will increase the BP. Kaya I have referrals as a cardiologist, not only coming from neurologists because of cerebral infarction, I also have referrals from gastro doctors. Kasi tumataas yung mga BP nila eh. Kunwari, there is mesenteric thrombosis. So mesenteric artery, this supplies muscles or intestine. And so if there is thrombosis, it will obstruct these arteries, and then there will be bowel ischemia. Once there is bowel ischemia, abdominal compression reflex will be stimulated, increasing the BP. Wait lang. Okay. So when a baroreceptor or chemoreceptor reflex is elicited, nerve signals are transmitted simultaneously to motor neurons that innervate the skeletal muscles of the body, particularly to the abdominal muscles. This compresses all the of the abdomen, helping to translocate blood out of the abdominal vascular reservoir toward the heart. As a result, there is an increased quantities of blood pumping into the heart. So if there is a drop of BP because of, let's say, blood loss, so the abdominal muscles will try to contract and then increase the venous return to somehow increase the BP. It is the same way if there is bowel ischemia, muscles there will try to contract. In fact, yung iba nga eh, parang hardbound na eh. Pag hahawak mo sa tiyan, hardbound na. Ganun yun. It's a mechanism to somehow increase the BP. Okay? So hindi ko rin ginagalaw siya pag mayroong bowel ischemia. Maingat din akong ibaba yung BP kasi pag ibaba mo yung BP, linalabanan mo yung physiologic response to increase the BP. So I hope naiintindihan niyo yung mga physiologic response na to. Because when you become a resident, it will be a problem. Ikaw yung unang humaharap sa pasyente. Ginawa mo lahat, binaba mo yung BP ng biglaan. Then by the time you call the consultant, nagagalit yung consultant mo. Kasi ikaw naman, wala kang ka-idea na mali pala yung ginawa mo. So, kailangan maintindihan nyo to. And I hope madadala nyo siya once maging resident na kayo. Okay? I think this is the last slide. So we will now open the floor to some questions. I hope naintindihan nyo yung topic. Itong topic na to is so useful to me as a cardiologist. Whenever I lecture this, pag pupunta ko sa patient, na-remind ako na, alam mo yun, nagagamit ko siya eh. Kasi ito yung bulk ng practice ko eh. A decrease in BP, an increase in BP. I have referrals na sobrang taas ang BP. Kailangan alamin mo yung cause because your management will differ. For example, it's a cerebral infarction, na stroke yung pasyente, ang taas-taas ng BP. That's why hindi mo ilo-lower yung BP ng biglaan. You have to compute for the mean arterial pressure and you just want to decrease 20% of that, not more than that. So kung napapagod ka mag-compute, you just don't lower the systolic BP below 160 millimeters mercury. You will be in the right track. Okay? Hi. Now, if it's a cerebral bleed, na-refer sa akin kasi ang taas-taas ng BP 210, I do a CT scan within cerebral bleed, iba naman yung mechanisms na gagawin mo doon because you know that if there is cerebral bleed, an increased BP will augment bleeding to the brain. And since ano siya eh, di ba, fixed yung skull, an increased bleeding, increased pressure, hindi naman nag-expand yung skull, kaya nagkakaroon ng loss of consciousness yung pasyente. So you want to lower the BP define rapidly, as rapid as you can, below by giving antihypertensive medications na intravenous. And by lowering the BP, you decrease the flow into that bleeding. Kasi yung, meron naman tayong mechanisms to close the bleeding. Okay, meron naman tayong mga anticoagulant something. But it will just take some time. So you want to help by decreasing the BP. Kaya ganun siya. So you will also have referrals like patients na merong bowel ischemia, mataas ang BP, you don't lower the BP as much as below 130. Hindi ganun yung goal mo. Iba rin naman pag hypertensive yung pasyente na walang mga ischemia, talagang mataas na yung BP. Then, you will learn that once you go into medicine. Bericionia. Doc, paano po ma-relate ang topic natin ngayon sa aneurysm? Yes, that is a good question. I don't know if you remember, last lecture may tumawag sa akin that patient was admitted in ACE Medical Center. Nang tumawag sila sa akin, admitted in ACE Medical Center, the patient is like a 45 female, came in because of left-sided body weakness and slurring of speech. She arrived with a BP of 230. And according to her, there is an increased family history of aneurysm. Mother niya, aneurysm. Kapatid niya, aneurysm. Kaya siya, they were thinking baka aneurysm din yung Kasi during the CT scan, bleed siya. There was a basal ganglia bleed. And so, sabi ko sa doctor na tumawag sa akin in emergency room, you start the cardipine drip agad-agad. And so, the cardipine drip has started. And I did an MRI of the brain. Wala naman siyang aneurysm. So, it was just a high bleed. Now, in aneurysm patients, you want, ang management sa kanila is, you don't want the blood pressure so high. So, you have to monitor their BP. Ang goal natin is a systolic BP less than 130. Yun yung goal natin sa kanila. And that's why you will be giving antihypertensive medications. Let's say ARB, losartan, that's example of angiotensin receptor blockers, losartan, valsartan, candesartan. And if it's still untreated, you don't achieve the systolic BP less than 130, you can give other antihypertensive medications, let's say calcium channel blockers. Ang example nyon is amlodipine, celodipine, mga pin-pin-pin. Pag hindi pa rin na-control, you add beta blockers, carvedilol, metoprolol, mga lol. So, pag hindi pa rin ma-control, you can give diuretics. Ito yung mga furosemide, aldosterone, mga ganon. Pag hindi pa rin ma-control, you can have centrally acting antihypertensive like clonidine, mga ganon. Ang dami mong magagawa. So, aneurysm can be seen on MRI. A CT scan na hindi plain, hindi yun makikita. Kailangan yun with contrast. So, kailangan siya, unless sobrang laki, baka makita sa CT scan na plain. So, dapat CT scan with contrast or MRI of the brain. Or, ang pinaka maganda na pag-diagnose sa kanila is if you do angiogram, cerebral angiogram. So, if there's an aneurysm, they will try to find what type of aneurysm. Is it saccular? Is it, ano bang isa? Fusiform, yes. Fusiform. And then, pag sobrang laki, then they will do surgery before it ruptures. Kasi pag mag-rupture siya, di ba kailangan mo siyang operahan within like 30 to 1 hours? Eh, hindi naman yan nangyayari sa atin in the Philippines. Kaya gusto mo silang ma-detect. So you go by history. History, they will have dizziness, headache, elevated BP, and then family history of them. Other than that, mahirap siyang ma-diagnose. Kasi pupunta sa'yo yung pasyente, high blood lang, bibigay ka lang agad ng antihypertensive. So, nadidetect ko lang siya if the patient is complaining a lot of headache. Then, I will request for a CT scan, plain lang muna, thinking of, let's say, infarction, cerebral bleed, or tumor. Then, pag makita kong negative yung plain CT scan, tapos nag-headache yung pasyente, taas pa rin yung BP, then I will try to hopefully, maisip ko si cerebral aneurysm. But ang hirap i-diagnose si aneurysm. Doc, did I answer your question, Berisho, or you would like to add a little bit more about that? Is this related to your family na may aneurysm? Or family member mo ba yung na-admit kong pasyente?
Previous case lang po, Doc, sa duty.
Okay. So,
about aneurysm.
When I was a fellow in St. Luke's, namatay si Isabel Granada, naalala niyo ba yon? Biglang tumaas yung mga pasyente nagpa-check up na gusto lang nilang magpa-MRI. Kasi natakot sila. So, ganun yun. Okay, let's move on. How does Von Clifford or Mineta, Doc, how does the sublingual medication work? Okay, you want to talk about clonidine as a sublingual. Okay, so we put it sublingually because wala nang first pass effect. It will be absorbed by the veins, in the veins, and then diretso na siya sa right atrium kasi ba superior vena cava yun, kasi sublingual superior vena cava, right atrium, diretso na siya. It will act now on the blood. Unlike if you swallow that, it will take like 2 to 3 hours or minsan 30 minutes. So kung sobrang mabilis siyang ma-absorb. Pupunta pa siya sa esophagus, stomach, intestine, and then i-absorb, go to the portal vein, liver, tapos mababawasan pa yung effect niya, yung dose niya sa liver, yun yung tinatawag nating first pass effect. And then by the time na dumaan siya sa liver, pupunta sa inferior vena cava to the right atrium, nandun na siya sa system, dun pa lang siya mag-a-act. So ganun siya. So this is how a sublingual medication is given. So meron tayong captopril, meron tayong tinatawag na clonidine. To tell you honestly, based on guidelines, we don't do that. There is no guidelines that say you put captopril and sublingual to treat acute hypertension. Wala siya sa book, wala din siya sa... Ginagawa lang namin yan. Parang yung mga senior, ganun ang mga ginagawa nila na wala namang explanation behind. So, pina-follow lang din namin. Ngayon na cardiologist na ako, I don't do that anymore. I don't advise my patients to, wala na akong magagawa kasi ginawa na ng mga residents ko. Kinokorek ko sila ng kinokorek ang titigas ng mga ulo. Ayaw din naman nilang maniwala sa akin. So hinahayaan ko na lang. Kasi hindi naman ako ganun ka-strict. But it's not correct. If the patient arrived with acute hypertension, let's say taas ang BP, you have to identify what's the cause of that. If it's cerebral infarct or cerebral bleeding, or other causes, kaya mag-history and peak, and by that you treat. If you need to lower the BP immediately, don't use sublingual. Kasi walang effect. Hindi yun malakas. Mapapansin mo yan if you go into practice, you just put captopril and captopril and captopril, walang effect. Walang future. Hanggang mamaya, nag-slurring of speech na yung pasyente mo. So, you do nicardipine drip. You don't do nicardipine IV bolus. Ayaw ko yun. Yung wala din siya sa libro, yung magbibigay ng nicardipine 2 mg IV now. Wala din siya sa libro, you just do drip. The good thing with a drip is because the effect is, for example, nag-drop yung BP, you can just close that or decrease. Kasi hindi siya naman biglaang ibababa, hindi din siyang biglaang tataas. So, yan yung maganda sa drip. Kasi for example, nag-start ka ng nicardipine drip, nag-start ka, let's say, 0.5 mg or tapos biglang bumaba yung BP, try mo siyang i-close. So, hindi ka na matatakot na magda-drop pa siya below 100. Ngayon, kung in-inject mo siya 2 mg, Diyos ko, day. Imagine mo, 2 mg na yung na-inject mo. Mailuluwa mo ba yon kung kung bumagsak na yung BP mo below 100, hindi na, di ba? Unlike by dripping, hindi ka naman nag-drip ng 2 milligrams per hour. You drip it by 0.5, so you increase it to 1 milligram, you increase it to 1 milligram, you increase it to 5 milligrams per hour. So ganun ka mag-decide. Okay? Did I answer that question? Sublingual? Yes, doctors do that, but as a cardiologist, my answer is it's not good. So how do we treat hypertension? We don't treat hypertension by sublingual. You want to give medications, oral medications with a long-lasting effect, 24 hours effect, that will control the BP less than 130, less than 140 without the need of sublingual drugs. Kasi ang pangit sa sublingual drugs is yung tinatawag na reverse hypertension. Yung binigyan mo siya, nag-drop yung BP, di ba meron kang mga baroreceptors, chemoreceptors? Ano ang turo ko sa inyo? So may rebound hypertension. Yung binigyan mo ng sublingual, bumaba yung BP, mamaya-maya, tingnan mo lang, tataas na naman yan because of what we call as rebound hypertension. The baroreceptors will be stimulated again to increase the BP. Yun yung hindi naiisip ng mga residents at saka nurses. So ako, as a consultant, Diyos ko Lord, ginagalaw na naman ng mga tridor yung management na hindi tama. Okay? So, past workmate ko po yung na-admit na pasyente. Oh, past workmate, kilala mo siya. Don't worry, she's okay now. Slurring of speech is out, she can talk. And then the left upper extremity weakness is now decreased. She can move the extremity already. The blood pressure is now okay, 130, 120. I tried to decrease the nicardipine because in-increase ko yung mga tablets niya. I have given losartan, amlodipine, carvedilol. So ganun naman in-start ko. So I was trying to lower the nicardipine drip. So the bleeding, clinically, I think it did not increase kasi okay naman, improving naman siya clinically. So I will decide if I have to repeat the CT scan in a week's time or not at all. But she's doing well. I allowed her to move around today. So, kilala mo pala siya. Di ba, what a small world. Alam niyo yung goal ko someday, resident ko na kayo, tapos mag-refer kayo sa akin na pasyenteng na-admit, and then, hello, bilisan mo girl kasi I'm doing a lecture in physiology. Tapos maaalala mo, oh my God, dati nandito din ako sa class ni Dr. Mambulaw. Tapos may mga tumatawag ng mga tridor na residents. Oh, sana ganun na rin kayo, no? Okay. Doc, do we need to give osmotic diuresis in patients with cerebrovascular accidents? If we're talking about infarction, it can be well controlled with calcium channel blockers, angiotensin receptor blockers. But if it's a bleed, it's a cerebral bleeding, you have to give nicardipine plus a diuretic. Ito yung binibigyan natin ng mannitol. So the purpose of the mannitol is not really to lower the BP, but yes, it can lower the BP. But the purpose of mannitol is to cause diuresis. Para pag mag-diurese yung pasyente, there will be, di ba mannitol, iihi siya kasi mannitol malaking mo, it will stimulate release of sodium in the proximal tubule. So there will be diuresis, no? So ang goal mo doon is to lower the edema in the brain. Kasi alam mo yung meron yung vicious cycle sa brain Ischemia, more edema, kaya dapat ka magbigay ng mannitol. So pag hindi ka magbigay ng diuretic sa cerebral bleeding, yung ischemia will further increase the edema. So the edema will further compress the cerebral arteries na hindi nag-bleed. So if you compress the cerebral arteries, you increase further the ischemia. So there is that vicious cycle. And that's why we give diuretics. Now, your question, cerebrovascular accident is particularly for patients with cerebral bleeding. For cerebral infarction, bihira lang ako magbigay ng diuretic. Nagbibigay ako ng diuretic if we call it, if that patient is, nakakalimutan ko tuloy yung term, resistant hypertension, hypertensive patient. So when we say resistant hypertension, you have already given 3 antihypertensive drugs, then that's why you have to give a diuretic. So pag nagbigay ka na ng diuretic plus 3 antihypertensive, that's resistant hypertension. So kailangan mo, ang hirap i-control niyan, magbibigay ka pa ng pang-5. So these are the types of patients where I give diuretic. medications or for osmotic diuresis. I hope I answered your question, Rico Bongalan Jr. Verana Joyce, if unconscious na po, Doc, ang big vein po ng brain yung nag-bleed, brain dead ba kaagad in relation po sa aneurysm? Okay. Aneurysm is more on artery, not on the veins, more on arteries. So, pag nag-bleed siya, magiging unconscious siya because tataas yung intracerebral pressure. So, yun yung nakaka-cause ng loss of consciousness. So, that's how you also differentiate cerebral bleed versus an infarct clinically. Pagdating sa emergency room, I think more of a cerebral bleeding than an infarction. Pero pwede naman siyang, di ba, unconscious yung patient pagdating sa emergency room. Pwede din siyang cerebral infarction pero napakalaking cerebral infarction. So, big vein, hindi, it's more of, aneurysm is more of artery.
Sorry, Doc, arterial pala. Doc, kasi it is my lolo kasi na aneurysm. Tapos,
Yeah.
yung sabi ng doctor sa amin na massive bleeding na daw. Tapos, gusto ko makuha yung yung MRI.
Yes.
Pero, pahirapan naman makuha kasi para sa
bleed, the management there is, alam mo, sabihin na, if you believe in God, there are mechanisms to control that bleeding. At saka hindi naman yan mag-bleed. So, ang ginagawa lang nila is if the bleeding is so big enough, then they will try to do a borehole just to release the pressure. So, you just want to release the pressure. Hindi mo naman makapasok yun to clamp that agad-agad. You just put a borehole and then to release the pressure. And then while waiting and praying na yung anticoagulant mechanism mo, mag-stop na yung bleeding. And then eventually, you will have time to do cerebral angiogram. And then there are mechanisms there. Peripherally, they can put a coil to close the aneurysm. Otherwise, after that, pag stable, pag hindi pa rin, you have an option to do a surgery to remove the aneurysm. But kung sobrang laki na ng bleeding niya yan, toxic siya, poor prognosis. I'm sorry. Okay, Joy?
Thank you, Doc.
Naka-nerve damage ba, Doc, yung naka-nerve damage ba, Doc, yung patient? Yaw, ano yung tanong mo, Bonnie?
Doc, ang regarding na po, Doc, sa patient na ACE, siya ba yung nagka-nerve damage?
Hindi.
Kasi may, hindi.
Hindi.
Okay.
Iba siya. Sorry, hindi. Okay, Clint Tyrone Capone. Doc, what if the patient is for an emergency operation pero mataas pa rin yung BP, di pa rin ba okay magbigay ng sublingual? No. I don't do that. Sorry. Okay, if the blood pressure is so high and the patient is for surgery, I will give nicardipine drip. And then wait. Minsan, yung mga surgeon, gusto nilang madaliin. I just start nicardipine drip. But do you know that you don't need to lower the BP as much as below 160, even if it's a surgery? So if start ako ng nicardipine drip and then papapuntahin ko na sa surgery, hindi ko masyadong binababa below 160 because pagbigay ng anesthesia, bababa pa yung BP noon. Yung mga anesthesiologists, alam na nila yan. Pero yung surgeon, gusto nilang, 160 pa. Ako naman, kalma lang, Doc. Diretso na tayo operation. Kasi kung mag-anesthesia pa yan, bababa pa yung BP pagbigay ng anesthesia. Di ba nakita nyo ba kanina pagbigay ng spinal anesthesia? Paano kung general anesthesia yan? Bababa pa yan yung BP because you inhibit the sympathetic tone. And so the BP will drop. Kaya kung sobrang ibaba mo yung BP, let's say 110 na yung BP mo, mag-oopera ka, baka mas bumaba pa yan yung BP. Kaya hindi ako masyadong And then, depende din sa pasyente, no? 160 na BP, hindi pa yung mamamatay sa stroke. Trust me, as a cardiologist, hindi pa yung mamamatay. Kalma lang. Okay?
So, mas preferably, Doc, mag-nicardipine drip na lang.
Yes, tandaan mo yan, nicardipine drip. Pero meron din namang magkakamali ka if you start a drip. For example, too much din yung drip mo, biglang nag-drop yung BP. Kaya, it's really a case-to-case basis. Sometimes, paano ba? A good example na mali yung decision mo to start a nicardipine drip. Tumating yung pasyente, masakit ang kamay. Because of pain, tumaas yung BP. Now, ang ginawa mo, binigyan mo ng nicardipine drip para ibaba yung BP. Hindi ka nag-isip kasi. So, dapat ang gagawin mo is you treat the pain, the BP will just go down eventually. Pero dito, ang ginawa mo, nilower mo yung BP. Hindi mo trinit yung pain. Nagigets mo yung point ko. So you have to go to history physical exam and then have a good mind and think what's really happening to your patient, then you can decide. But if the increase in BP is talagang iba naman yung cause, let's say bleed or infarction or talagang hypertension uncontrolled, then you are in the right track if you start nicardipine drip. Kasi hindi yan biglang bababa yung BP. Hindi yan biglang bababa.
Doc, ano po yung mas tama pa rin if i-compare mo yung nicardipine drip sa nicardipine IV push talaga?
Wala siya sa book, IV push. Wala siya sa book. Pati tingnan mo yung nicardipine medicine, wala siyang nakasulat doon na give 2 milligrams IV now then start a drip. Wala siya doon sa ano niya Wala siya doon sa, anong tawag niyan? Whatever. Wala siya doon. Tingnan mo. It's really not in the book and it's really not, hindi siya tinuturo. These are practices na ginagawa ng mga doktor without basis at all.
Okay, Doc. So,
hindi ka pa ba
thank you.
na wala siya sa book?
Hindi, naniniwala ko. I just realized na
You see that, no? Kitang-kita mo siya, nagpo 2 milligrams
yes.
siya.
Oh,
Sa chart ko yon, hindi sa akin yon, yung resident ko yon, nakapera lang ako kasi they inject already 2 milligrams. And then, hindi naman ako toxic na consultant. Parang, okay, sige, you start the drip. Pero hindi ko naman binabatukan na bakit ka nag-2 Wala naman siya sa book. Girl, magbasa ka kasi ng libro. Mag-aral ka kasi ng chapter ng hypertension sa Harrison para alam mo yung ginagawa mo. Start to treat. But you see that in practice. However, if you see that in practice, wag mo naman, Doc, ang bobo mo, hindi mo alam, bawal yan, wala yan sa book. You have to work amicably to your colleagues. So there's time when you want to correct. There's also time na you just hold on to what you know. So I hope kayo as a student, you will know para hindi niyo gagawin yung hindi tama.
Okay, Doc. Kasi po before I just remember if we have patients na for emergency talaga, pag di tumatalab na yung mga yung sublingual, yun yung yung
milligrams, tapos wala pa rin, bumaba bigla, no? Kaya pasok. Di ba most of the time because of pain yon? Don't you think? Acute abdomen, because of pain. Abdominal reflex. Tataas yung BP. So what do you do about that? Kailangan mo ba ibaba ng biglaan? Hindi, increase mo yung ischemia. Kaya minsan nag-iisip tayo ng maayos, no? Minsan kasi pag nasa emergency room ka na, di mo na ginagamit yung knowledge mo sa physiology. Kung ano na lang yung practice ng mga seniors mo, yung nakikita mong ginagawa ng mga seniors mo, ginagaya mo. But ako hindi. I don't do that. Okay?
Okay, Doc. Thank you.
Doc, yung nifedipine sublingual, mas okay ba kesa sa captopril? Okay. We have a problem with nifedipine, kaya bigla, dati sobrang gamit na gamit siya sublingual as para biglang ibaba. And then biglang nakita namin na sobrang daming nag-heart attack. Kaya kung mapapansin mo ngayon, halos wala nang gumagawa niyan because of increase in heart attack. Kasi ang nangyayari kasi, you drop the BP immediately. And then, because of that, you provoke ischemia. Then after a few minutes, there will be rebound hypertension. Dami din naman na-stroke. Kaya we don't do that anymore in nifedipine. And if you compare nifedipine and captopril, you are wrong already in that question because we don't do sublingual. Sorry ha. Ako kasi yung tinatanong mo. We don't do that. If
Kasi,
you're asking me
oo.
if better
Hindi kasi, Doc, may ibang physician na binibigay yung ni Philippine as sublingual. I mean, pati yung captopril. Hindi ko lang sure kung... Pero hindi pala yun.
Hindi. Mali yun. Pero huwag mong sabihin, Doc, according to Doc Mambola, wrong yun eh. Sabihin mo, according
okay, Doc.
to wrong yan.
Sige, Doc. Thank you.
Okay. What is the management for if the patient ay may mataas ang BP and slow pulse rate and experience shortness of breath? Okay. The treatment of bradyarrhythmia, if the BP is below 90 millimeters mercury, then you either hydrate immediately. If hindi pa rin, you give atropine. Pag hindi pa rin, you give dopamine, norepinephrine, dobutamine. Yun yung mga choice mo. Pag hindi pa rin, then baka mali yung assessment mo, baka pacemaker yung kailangan. So yan yung algorithm. So depending what type of arrhythmia, it's a third-degree EV block. Walang effect yung mga atropine, dopamine, keme-keme, kahit anong gawin mo, talagang walang effect yan. Kaya ang kailangan kasi niya is pacemaker. Because the atropine will try to act on SA node to increase firing. Di ba hindi nga nakakapasok sa AV node pag third-degree EV block? Kahit anong gawin mo, walang pumapasok. Kaya useless yung mga pinagbibigay mo. Pacemaker yung kailangan. You have to stimulate directly the ventricles to contract at 60 beats per minute to increase the BP. So, arrhythmia, depende yan kung ano nakakakos ng slow pulse rate. Minsan, nag-slow pulse rate siya because let's say junctional. Very good! Last night, hindi ako nakatulog kagabi because at around 2 o'clock in the afternoon, the resident called me, Doc, yung patient daw, junctional rhythm, 30 beats per minute, and then mababa yung BP. Galing siya sa isang ophthalmologist kasi nag-check down ng glaucoma. Okay? So, sabi ng resident, nagbigay daw siya agad ng dopamine. Sabi ko, girl, magbigay ka ng atropine. That is because of the effect of the dilator medication na binigay ng ophthalmologist. So, pinibigyan ko ng atropine, nag-improve agad yung heart rate, 60, tapos nagsa-sinus na siya. Okay? Oh! So, kailangan magaling ko mag-isip, no? Para na ma-manage mo. Yung resident naman, wow, doc, talaga? Diba? Ganun. So, maganda yung may nagagawa kang tama. Okay. So depending what causes the slow pulse rate, it really depends. You have to look at the ECG. And then depending kung ano yung cause ng drop in BP, sometimes a good example there is nag-acute diarrhea yung pasyente, dry na sa, alam mo yun, dry na yung pasyente, huwag kang mag-dopamine ng dopamine, you hydrate. I-hydrate mo yung pasyente. Okay? Minsan din, alam niyo bang there's a type of myocardial infarction. If it's an inferior wall infarction, it will, we have this basal gyrus reflex. Ako, ang ganda niya. Lumalabas siya sa mga quiz B kasi pang matalino siya. Basal gyrus reflex, this is a type of inferior infarction because of obstruction of the right coronary artery. It will cause a decrease in BP and a decrease in heart rate. Then if that's the type of problem you have, then you have to treat the infarction. Let's say, aspirin, clopidogrel, bigyan mo ng streptokinase kung STEMI yan, or ilagay mo sa cath lab. I hope I answered the question, Ara. Laswela, good morning, Doc. Curious ko lang po. Oh, ang daming question, I like it. Curious ko lang po, you mentioned that at some point, the baroreceptor reflex and chemoreceptor reflex work together. Yes, if the BP is below 80. Does this mean that the baroreceptor reflex was, for a lack of a better term, inefficient? No. Kasi biglang, meron kasing drop of BP na hindi dumaan sa 90. Alam mo yun, biglang drop siya 70. 110 siya, biglang 70. So they will act together. Okay, for a lack of a better term, inefficient or decrease in BP was too much for the said reflex to handle. They just work together because if the BP is below 80, they work hand in hand to increase the BP para mas powerful, mas stronger. The baroreceptor reflex, the chemoreceptor reflex kasi will not work if the hindi pa siya na-stimulate eh, if the BP is not yet below 80. Or even if the BP is 90, As long as there is low O2 and high carbon dioxide, high H+, it will act already. Nagigets niyo ba ako? As long as chemo kasi siya, so if there's a change in this chemicals, even if the BP is not below 80, it will work. Now, they work hand in hand to serve a purpose of increasing the BP. Hindi sila competition. Wala silang competition. Mas powerful si chemo. Mas powerful kami. Hindi, wala silang competition. They just want, it's a reflex kasi. Walang pag-iisip yan eh. But when we talk about reflex, there's no consciousness. There's no work of the cortex. It's a reflex, so walang competition siya. Their purpose is just to increase the BP. I hope I answered the question. Doc, what can be the most possible cause of sudden heart attack if the patient has normal ECG and vital signs, conscious but is experiencing chest pain as an initial assessment, and what can be the management? Okay. There are three things that came out into my mind with that question, Carissa. One is aortic dissection. I have a patient, 32-year-old male, and then chest pain in naval. Tapos, nasuntok daw siya sa chest. So, anyway, after a while, pinauwi after 2 days. Pero chest pain pa rin ng chest pain. Dumating sa emergency room, drop yung BP. This is apparently a healthy male. And then, bigla na lang siyang namatay. Aneurysm diagnosed. Buti na lang before siya namatay, na-to-the echo ko siya. So, I was able to see the dissection on the aorta, ascending aorta, as well as on the descending aorta. Ang laki. And then, looking back on the patient, he has Marfan's syndrome. Marfan's syndrome, so this is a connective tissue abnormality kung saan yung artery, yung vessels, walang connective tissue, kaya dilated sila. So the aorta are all dilated, it will cause aneurysm and then eventually dissection. The second thing, maraming patients na, I have another patient, guwapo, bata, nag-basketball lang, biglang namatay. These are cases of patients who has meron silang Brugada syndrome. Narinig niyo ba yon? Brugada syndrome? Brugada syndrome is the cause of bangungot. That's the cause of bangungot. So it's a congenital anomaly kung saan meron kang abnormality sa sodium channel in the heart. Diba we have talked about sodium channel? So if you have an abnormality of that sodium channel, these patients can have arrhythmia. So magkakaroon sila ng arrhythmia, ventricular fibrillation. So bigla na lang silang namamatay either during sleep or during activity. So it can cause sudden cardiac death, and that is very common. That is common among Filipinos, yung Brugada syndrome. So maybe you want to look up into that in the internet. That's the cause of bangungot in the Philippines. Hindi siya pancreatitis, baka hindi nyo, up till now, ang alam niyo ng bangungot, ang cause is pancreatitis. Acute pancreatitis, mali yun ha, the cause of bangungot is Brugada syndrome. It can cause sudden cardiac death, and these are seen in males with congenital anomaly of the sodium channel. Naniniwala ka ba?
Ano po spelling, Doc?
B-R-U-G-A, Brugada. So, there are a lot of causes of sudden cardiac death in an apparently healthy person. And another problem is HOCM, hypertrophic obstructive cardiomyopathy. Or they can also have abnormalities, congenital abnormalities. Pinanganak silang merong mga abnormalities sa mga whatever, yung let's say, yung mga AV node, lahat yan, yung mga pathway na yan, kung may problem yan, it can cause death. That's why, kunwari, papasok ka, magpupulis ka, pinami-ECG, itinhira, and then we will be able to detect somehow they have Brugada syndrome or Brugada pattern. Kasi ECG, ang first diagnosis ng Brugada, may makikita kang ST elevation na kakaiba, saddle shape, doon sa V1 and V2. But there is a big topic. Sudden cardiac death is a big topic in Harrison. That's one chapter, which I will talk about on November 7 via Zoom to my residents and interns. I hope I have answered the question, Carissa. Tijerero, what is the ideal BP range po, Doc, while using the cardipine drip? Okay. Map, you have to compute the map. If you don't know how to compute the map, don't try to treat patients with cerebral infarction. Kasi you want to lower the BP but not as much. So you have to compute for the map. Okay? So you just want to lower 20% of the map in the first 1 to 2 hours. Then after that, then you lower the BP na eventually. You don't lower the BP below 160 in the first 5 to 6 days of cerebral infarction. Magagalit sa'yo yung cardiologist at saka neurologist. Kaya nga pinagtatatanggal ko muna yung antihypertensive medication. Pag cerebral infarction yung pasyente, refer sa akin yung nurse at saka yung resident. Kasi yung BP ng pasyente is 150, 160 at ako naman walang ginagawa. Agree ba kayo na wala na tayong gagawin? 150 ang BP, cerebral infarction? Or ayaw nyo pa rin maniwala? Because it's the CNS infarction response. You don't do anything about it. In fact, yung example ko sa inyo, noong 1980s, binababa nila agad-agad yung BP. They want the BP 130, 140 in the first 24 hours after cerebral infarction. Ang tataas ng mortality. So when you become a resident, we will teach you that you don't do that because that's not good. According to the guidelines, we lower the mean arterial pressure, 20% of the mean arterial pressure in the first 1 hour. Then by that time, we just want to maintain the BP above 160, but not above 200. So 160 to 200, yan yung sa guidelines. Okay? Emergency medicine criteria for alarming BP is having a 180 systole. Yes. We have, let's say, hypertensive urgency, hypertensive emergency. These are terms. Pagdating ng pasyente sa emergency room, mataas ang BP if the blood pressure is more than 180, na wala naman siyang neurologic symptoms at hypertensive urgency. And then pag meron na siyang neurologic diseases, hypertensive emergency siya. So yung pag-treat mo pa rin is hindi rin biglaan. Kung 180 yung BP, just give nicardipine drip. Kaya ayaw kung magbibigay ka ng 2 mg kasi baka biglang bumaba siya. You just start the trip and then slowly decrease within 1 hour hanggang 160 millimeters mercury. Not too fast naman. Kasi pag bigla mo yung ibaba, baka makakos ka ng CNS infarction or ischemia. I hope naintindihan niyo yun. I hope may natututunan kayo sa akin. I was na postgraduate course in the PCP. Ako yung scientific chair. Talagang nilagay ko siya sa isang topic about how to treat acute stroke. Because when I came back sa Philippines, from pagdating ko dito sa Tacloban City, pag may dumadating na stroke patient, nakikita ko lahat gusto nilang ibaba. Ibaba yung BP, nicardipine drip. Gusto nilang ibaba yung BP na i-stroke ako. Because in St. Luke's, we don't do that. Like pag 180 yung BP, wala. Nangalang kami. Yung neurologist, yung cardiologist, nagkakaintindihan na wala kaming gagawin. We will just observe the patient. Gustong-gusto namin na mataas ang BP pag stroke, cerebral infarction. Because it's a normal physiology. If you do anything about to lower the BP, you increase the ischemia and the infarction. Pagdating ko dito sa Tacloban, talagang gusto nilang ibaba. Ikaw naman, syempre, di ka re-referan. So, parang nape-pressure ka. And so, I wanted that topic to be on the PCP convention. Kasi gusto kong malaman ng lahat ng mga internists na don't do that. Don't lower the BP. Dalawa lang ang neurologist natin dito sa Region 8. Di ba? Nakakaloka. Dalawa lang sila. Tapos, pag nare-referan sa kanila, maayos yung management. Pero pag walang neurologist, nakakaloka na yung pasyente. Kasi yung mga resident at lahat ng mga doktor, na-stroke ako. Gusto nilang ibaba yung BP. I hope kayo as a student, malaman yung hindi. Please read Guyton. Please read Harrison. It's in the book. You don't lower the BP as much as less than 160. You just lower the map 20% from the map if it's more than 200. I hope convinced na kayo na you don't do that. Bakit po, Doc, hindi magbibigay ng beta blockers pag nagpo-coronary vasospasm yung patient? Okay, Nare-remember ko lang sabi ng resident sa akin, yes, that is true. Because ang tinatawag na, para yung hindi alam, when we say vasospasm, this is a problem na pag angiogram, normal yung size ng coronary arteries. Walang mga atherosclerotic plaque. Normal siya. Pero yung pasyente, chest pain ng chest pain, yung if there is an event, let's say activity, nagko-constrict yung, alam mo, nagva-vasospasm, nagko-constrict yung coronary arteries, decreasing blood supply, causing ischemia. Tapos, pag wala na yung event, wala na yung nakakakos ng constriction, nagda-dilate na naman siya. So, ano lang siya. So, you don't give beta blocker because if you lower the heart rate, you lower the BP, tapos nagva-vasospasm yung pasyente, you are increasing ischemia. Naintindihan niyo ba yon? Ischemia is an imbalance of oxygen and supply. So, there is a vasoconstriction, wala ng blood supply sa myocardium. Ngayon, ang nakakabuhay lang pasyente if the blood pressure is a little bit higher because that pressure will try to push blood across the constricted vessel. But if you lower the BP, wala ka ng perfusion, just kuday. Wala ng perfusion, wala ng BP, may vasospasm pa, may constriction pa, you increase the infarction, you kill the patient. So don't give anything that will first do no harm, di ba? Yun yung ating ang ating concept anyway. So the treatment of vasospasm is you give calcium channel blockers because calcium channel blocker will try to inhibit calcium. When you inhibit calcium, you relax the vessel. When you relax, you treat the vasospasm. I hope I have answered the question. For a massive cerebral bleeding, doc, bleeding is at the center and it does not stop. Diba, we want to keep the BP high enough? What if the patient does not respond well to the medication? We want the BP high enough. I want the BP low. Bleeding kasi yun eh. Increased pressure, increased flow. So, more bleeding. Iba kasi yung pathophysiology nun eh, nabutas si artery. Kaya, wala kang magagawa dun eh. So, you have to lower the BP to decrease the flow across the bleeding. Para siyang gripo eh. Tulo na siya ng tulo dun. Now, what if the bleeding does not stop? The patient will die unless you do anything to clump that bleeding. So, ang ginagawa lang ng neurosurgeon is they do a borehole to release the pressure. Yun lang muna while preparing for the surgery. But if the patient does not respond well to the medication, the patient will die. Like if the BP still keeps down despite the medication, the BP patient will die. Is it already safe to say we can go no longer to management? Yes, because the patient will die. I'm sorry. No. Minsan pag alam mo, as a doctor, pag marami ka nang alam, you will know which patients have poor prognosis. And you don't say, Mom, the patient will die. Don't do anything about it anymore. He will die. No, you have to be, if you cannot do anything, the best management that you can do is comfort and compassion. Tandaan niyo yan. Kahit wala kang ginawa, pag compassionate ka sa pasyente mo, okay na yon. Di ba meron tayong tinatawag na patient experience? Kunwari, umuwi siyang buhay, pero yung experience niya sa hospital hindi maganda, hindi ka pa rin ma-appreciate ng pasyente. Pero yung pasyente umuwing patay, but sobrang na-appreciate nilang maayos yung pagkakatreat sa kanila, they will live happy. I mean satisfied. So patient experience is important. So in that case, if there's massive cerebral bleeding, the patient will die because poor prognosis. Ang pag nag-bleeding, cerebral bleeding, you just pray that your own anticoagulant will work to close the bleeding. So you just try to lower the BP just to decrease the bleeding, but you are not doing anything to prevent the bleeding. I mean, wala kang ginagawa doon sa mechanical damage. So gusto mo lang siyang dadasal-dasal ka na lang, hindi na lumaki ng lumaki. So pag lumalaki, pag nasa center kasi yung bleeding, pag lumalaki ng lumalaki, let's say nasa basal ganglia siya, hindi mo naman yung tutusukin, no? From the brain papasok Kasi ang dami mong madadamage na cortex ang nasa. Ganun din eh. Tapos papasok ko susuyo. What we do is just do a borehole just to release the pressure, and then the neurosurgeon will pray na mag-stop na yung bleeding. As a cardiologist, what lower the BP, because the concept there is you lower the flow, you lower the pressure, you lower the flow, you somehow decrease the bleeding. But you will still wait and pray for the bleeding to stop on its own. Pag hindi siya mag-stop on its own, kahit magaling ka pang neurologist at magaling kang neurosurgeon, the patient will die. Okay? Tranexamic acid is a drug that has been not very effective controlling bleeding. So try to look at the study. It's not robust. It's not like sabihin natin out of 10,000, 9,000 yung na-prevent yung bleeding. So hindi siya ganun ka. That's why as a cardiologist, I don't do tranexamic acid. And we know for a fact na hindi siya ganun ka-effective, pero we still give it for whatever it will try to prevent bleeding. But yes, we give tranexamic acid. But when you go to medicine, I mean, pag third year nyo, or when you go to fellowship training, you will know that tranexamic acid is not really that effective to prevent bleeding. But yes, it can prevent bleeding, but not very strong. So, pag-aaralan nyo yung cascade, yung mga cascade ng prothrombin, whatever, pag-aaralan nyo yan dyan. When you learn about that, then mag-usap tayo. What's the effect of tranexamic acid? Okay? Oh! Let's yung brain nyo. Doc, not topic related. How do you feel as a physician when a patient of yours died? At first, umiiyak talaga ako. So yung pinaka-naiiyak ako pag may anak na namamatay, yung mother nila, naiiyak ako doon. Or kunwari, pag pagsasabi yung mga anak na, mawawalay na magbabantay. Yun, naiiyak ako noon. But it has been a practice na wag ka daw iiyak in front because you are the physician, you are the stronghold, ikaw yung captain of the ship, so ayaw mong magpakita ng weakness kasi sila huhugot sa'yo ng strength. So kung weak ka rin, so you try to be confident but not arrogant. Magkaiba yun. So confident na compassionate. So sabihin ko na lang, because somehow I am bading, no? Pag bading kasi medyo medyo soft, soft. That's one of my strengths siguro. So I tend to be compassionate to my patients. But anyway, I still feel bad if my patients die. Tapos, pero yung emotions mo should change rapidly. Because pagdating mo sa isang patient, alam nga namang, I am sad. Namatay yung patient ko sa kabila. Doc, mamamatay din kami. You don't do that. Kaya yung emotions mo should change, and you will know that once you go into practice na mag-change. Dito, hindi ka plastic, but you just try to be compassionate. And pagdating mo, you compose yourself, and then you rounds ka only sa isang pasyente. Ganun yun. And that's the reason why we don't treat our own family. Kasi kung mamatay yung family na ikaw yung attending physician, ang hirap mo makarecover. So, ang gagawin mo is you let the other physicians treat that. Huwag kang makialam. Kasi wala din namang bayad yan. Di ba? Kasi maraming example na yan. Yung mga doktor, silang nagmamanage sa mga family na tapos namatay. It takes them 1 year to 10 years before they go back to practice. Unlike, syempre, kung hindi mo naman yan, kailangan you are needed by other patients. At saka hindi naman sa araw-araw, 10 patients, 9 ang na-discharge mo, isa lang naman ang namatay. Don't, I'm a bad doctor. You are still a good doctor. You have saved 9 patients, 1 dead. So, ganun lang. Pero kung let's say 9 dead lahat, puro mga benign, think twice. Baka marami kang pinagawa ng mga kagimbal-gimbal. And that's exactly the reason why I trained. Gusto ko, when I graduated College of Medicine, pumasa na ako sa board exam. Pag uwi ko sa Borongan, amoxicillin lang ang alam ko. Bobo pa rin ako. I trained to internal medicine. Pag graduate ko ng internal medicine, bakit parang hindi kulang pa? So, nag-fellowship training ako, nag-cardio ako. Pag cardio ko, bakit sa cardiology ang lawak-lawak pa niya, no? Cardiology na nga yun. So, nag-train pa ako. So, yun, yung pagbalik ko dito, yun na, ang dami mo nang natututunan. When you learn more, then you become confident and then more experience, and then that's time you can give proper treatment sa patient. So, ang dami kong marireceive, re-refer sa akin, thank you, na-refer sa akin kasi hindi nila alam how to manage. Hindi naman sa hindi nila alam. Pero, anyway, basta, pag alam mo, and then you know what to do to the patient, na-treat mo, ang ganda, mapapauwi mo yung pasyente ng maayos. Unlike wala kang kaalam-alam. Alam niyo ba kung bakit ako nag-cardiology? I graduated at third year na ako in medicine. Tapos dumating na pasyente sa emergency room, yung second year resident ko, tinawagan ako, Doc, yung pasyente nangingitim yung paa, below the ankle. Tapos when I referred after 2 hours, nasa ankle level na. Yung akong second year resident, wala upayang pag physical exam. Lusad ko naman. Pag lusad ko, on the ankle. After 1 hour, nasa middle na siya ng leg, ng nakakaloka. Then eventually the patient died. And I didn't know what happened to the patient. Ang nakalina akong isipan, tukog ko din sigbin. Tukog ko din sigbin until siya nga namatay. So, di ba, ang pangit nun? You don't know what happened to the patient. You don't know what's happening to the patient. That's why you don't know what to do to the patient. And that's why the patient will die. So, present ko itong patient in a grand rounds. And I was so amazed. 3 cardiologists was in the grand rounds and they told me that's a typical example of acute limb ischemia. And the treatment is you give anticoagulants. If still not treatable, you putol the paa and the patient will survive. Yun pala yun. So see, that simple knowledge will make a difference. Best way to control a bleeding is ligating the bleeder itself. Right. But what if nasa loob siya? No? Hindi mo naman siya bubus-busan agad sa emergency room and then clot the bleeding. So you have to buy time to bring the patient to the operating room. And so you just try to control the BP. Decrease, but kailangan ko rin mag-isip, not too much, no? So what you do if there is bleeding, depende sa type of bleeding. If it's an abdominal bleeding, ginbuno, no? Ginbuno. Tapos nagdudurogo, babsak. You have to hydrate. Give Voluven, kung wala pang Voluven, you hydrate with crystalloids, and then you start norepinephrine, dopamine to vasoconstricted vessels to somehow increase the BP while naghahanap ng dugo. Kasi yung dugo naman, di ba? Just Lord, yung mga nurse din, alam niyo. Hindi naman like 1 hour lang, agad-agad nag-transfuse ka na. So, habang naghahanap ng dugo, pupunta ng emergency room, you buy time. That's your role as a physician, as an internist. You buy time for the surgeon to go to the operating room. You hydrate, you give inotropes. Yun lang yung magagawa mo before mag-ligate. But yes, you ligate the bleeder. Pero for example, the bleeding is in the artery in the basal ganglia. Paano mo naman malaligate yun, no? Hindi mo malaligate yun. Para buksan mo, pumasok ka sa basal ganglia na nasa gitna, ang dami mong madidestroy na cerebral, yung mga neurons. So, di patay din yung pasyente. So, case-to-case basis. Oh, you're learning. Marami ba kayo natututunan? Questions? I hope I have answered all the questions. It's 12 o'clock. Pangaon na. Wala pa kaman pag-round. So, if you have more questions, you can contact me via Instagram. All right. Thank you very much. Happy lunchtime. Bye-bye.
Bye.
Thank you, Doc.
Bye.
Thank you, Doc.
Thank you, Doc.
Bye, Doc.
You know.
Thank you, Doc.
Thank you, Doc.